Welcome everyone to our webinar today on the intersection between value-based care and fee-for-service. My name is Nabil Kaukab. I'm the founder and CEO of John Health, and we're the makers of Family, the leading chronic care management platform out today. Started the company a few years back after kind of a long 25-year career at the intersection of healthcare technology, and this has been a personal passion of mine. Really, but how do we take care of patients beyond just the office setting? As we all know well, healthcare extends beyond the four walls of the hospital and the clinic. And how do we serve patients beyond just their quarterly or even monthly visits to see the physician and the healthcare team? But with that, though, everyone's here not to hear me, but really to hear our distinguished guest, Lisa Stockdale, who is a healthcare leader who focuses on improving populations of patients by transforming care delivery towards prevention and care coordination. Lisa's been in healthcare for over 20 years in a variety of roles, including sales, business development, strategy and planning, value-based care, and digital transformation over the past 8 years at Silver Cross Hospital in particular. In previous roles, Lisa participated in healthy living programs that supported the teaching of lifestyle interventions to improve and reverse metabolic disorders for patients on the south side of Chicago, and earned the 2019 Employee Live Green Live Well Award. Lisa has a real passion for humanizing healthcare and creating personalized care at scale. But more importantly, I've had the luxury of knowing her for a couple of years and just know she's an amazing person, not only professionally, but on a personal level as well. Lisa, you and I had the chance to kind of start this dialogue a couple of years ago. We were introduced by a former colleague of yours to talk a little bit about not only kind of what we do as a company, but more importantly, our mission of serving patients beyond just the clinical setting. And I think that mission is really what kind of started a lot of our early conversations. Do you want to talk a little bit about, your mission at Silver Cross and what you're looking to do, how you guys approach the world of healthcare?
Yeah, well, the mission here at Silver Cross, and thank you all for jumping on today. I know everybody's really busy and appreciate that. And just wanted to give a quick shout to Ben. It's kind of really coming full circle because I spent a lot of time listening to webinars with subject matter experts all over the country. And it's really my hope today is that you leave today with possibility. Today is about opening your mind to possibility, and that what we're doing is not possible without family. So this is really, truly a partnership. I just happen to be in a really amazing institution. Silver Cross Hospital is a little over a 300-bed facility, but we have the lion's share of our market in southern Will County, just about 45 miles south of the Chicagoland area. And, we just have an exceptionally engaged physician community here. And I've had the pleasure and the honor of working shouldered up to our physicians for a number of years now. Our mission here is really to advance the health of the community that we serve. And so this program that we're going to talk about today is really just a physical expression of what I see of how I can contribute to advancing the health of the community. And, just continually humbled by the care teams that we have here. Thinking back, I was reflecting before we started the meeting today about the pandemic and just really where that's left us all in healthcare, and really want you to take today as an opportunity to think about how we can serve our patients and our consumers. And I'm going to use the word consumer and patient interchangeably because it's really incumbent on us as healthcare leaders to change the conversation, because we are all healthcare consumers. And this program was really designed from that vantage point. I think we oftentimes get caught in the minutia of healthcare of all the different stakeholders. And we'll talk through some of the challenges we had initially presenting this concept. But at the core of it, I never left the patient as the center of why we did this. And that's really why you see what you see today. The patients are engaging and they're adopting the program, and that's better than any technology or innovation that we can come up with.
Thanks, Lisa. Appreciate that background. So as you know, today's conversation is really about the intersection of value-based care and fee-for-service. Value-based care is a topic that's really started to gain some popularity over the past several years. And obviously, you and your team at Silvercross have actually been at the forefront of it for quite some time. I think the market is finally catching up to where you've been all along. But let's think back to a couple of years ago when we first met. What real challenges did you and the team at Silvercross really face in meeting your value-based care goals?
So specifically, we'll kind of talk about the Medicare Shared Savings Program, which is what this chronic care program is influencing. But again, think possibility, because this can really go across commercial lines of business, Medicare Advantage. So it's really incumbent on you, depending on where your organization is at in the value chain, and what can you do to bring that to the table. But you know, I've spent a lot of time under the hood in primary care offices and looking at the quality measures and the cost factors that we are tasked with through these value-based payer contracts to achieve, and then looking at the current construct of the primary care setting and realizing that we're just trying to solve the wrong problem. That if 80% of someone's outcomes are influenced by their social environment, where they live, where they work, access to food and good, strong family connections and community, a regular job, and our poor providers are being graded on that outcome, but we've done nothing to solve for that social piece, and really just trying to figure out how to help transition the physicians from a mindset of a medical model to a chronic care model, because 80%, and it's probably closer to 90% of our Medicare beneficiaries have 2 or more chronic conditions. And the complexity of what those patients have to figure out while they're at home, 360 days, as Nabil said to me when we first started talking, of the year, without really sort of that medical professional guiding them through those decisions on a daily basis. That's what we see influencing those patients' outcomes. And it's really just come full circle with our chronic care program, and the stories that I'm getting on a constant basis about how this program has made a positive influence in someone's life. And I'm sitting here looking at all the claims detail and how many care gaps this person has and what diagnoses they have, and really just looking at it from a medical mindset and being able to open my thinking up to what's actually influencing these people on a social level. And then how can I equip our team to be able to address those social needs that our patients have? And it's really just been wildly, remarkably just positive all the way around. So look forward to sharing some of those.
That's helpful. Let's pull on that thread just briefly. If you had to think about, and I think you hit on some of this to a degree, but if you had to sort of summarize it, what does success really look like to you in your role as a value-based care director?
Success for me is knowing that the patient's outcomes are really moving in a positive direction. I think, fixing the healthcare system is not just on the provider side. It's not just on the payer side. It's not just on the policy side, but we all sort of have to come to the table together. And as providers, we have to open our thinking up to being able to, again, address these social issues that are affecting patients. And I think that's really, one of the main things that we've learned as we've been going along is how to do that. So success for me is consumer adoption, because if I can get the patients to adopt this program, then we can positively influence their health over the course of days, weeks, months, years. We just crossed our 1-year anniversary, so we do have a number of patients that have been engaging with us for about 12 months. And I think really exciting that Nabil, you and your team are going to help us, look at our outcomes and really be able to prove that we see those care gaps being closed, that we see those patients coming in for annual wellness visits, that those patients are more tightly aligned to their primary care physician. We leave people out there to make super complex decisions about their health without any support and guidance. And I would say that's probably the most common response from our patients is they feel like they have someone that they can go to help them with these types of questions. So that to me is success, is really that the patients are adopting the program and they continue to find value in it.
Love hearing about that. Your passion for you and your team really shines through in all the work you've done and the way you describe it. Let's shift gears slightly, if you don't mind.
Sure.
Want to talk a little bit more about how you've used chronic care management as a new service line for the hospital. And when you think about it, when you're looking to improve these value-based outcomes, right, that you think of as your key success criteria, why did you decide to look into a fee-for-service program like chronic care management?
Yeah, that's a great question. I think, when you get into the value space and you start talking about, what is value-based care, how do we, sort of deliver that quadruple aim, and that now includes the provider. Okay, so they're a huge piece of this equation. Again, the program was designed with the patient at the center, but all the stakeholders have to really, come to the table and work together, because at the end of the day, the provider is sort of the quarterback of the patient's care. And that's really what I wanted to design this program to support the physicians as well. Why do I see it as a service line? Because even though I'm in a Medicare shared savings program and we're an enhanced track APM, which is the most financially risky program that you can be in today besides direct contracting, we all operate under fee for service. That's how we're currently getting paid. And so when I took a step back, I said, why don't we design a program that we get paid for that actually also does the right things for the consumer? And so, the reimbursement that we're collecting today, we just want to be fiscally responsible and make sure that's covering the cost of the staff. But the end game is really, one, the outcomes, and two, that the patients are happy and engaged with us, because they will then carry, their care journey will stay with us over their continuum of their life. So that's really why CCM was important, because the activity that's getting done within the physician practice on a day-to-day basis is not captured or not reimbursable, but that time is critical to preventing adverse events. And we've already seen a number of those things come up through our program. And I'll just speak to a few examples here. We had a patient that just reported that she was feeling a little short of breath. She was talking with one of our nurses, and our nurse was, doing a great job triaging the patient and really was trying to encourage her to come into the office. And she has COPD, and she was really attributing that shortness of breath to being delinquent and seeing her pulmonologist. And maybe I need to follow up with them. And day 2 comes, and we're, really trying to encourage her to come in. She finally agreed, saw her primary care physician at 2:00 the following afternoon. She was immediately sent to the hospital for a procedure, and she was stented. She had a blockage. She was approaching a heart attack, or was really in the early pieces of that. And so when you look at being able to positively influence someone's life by intervening soon enough that you're preventing them from having an adverse event like a heart attack or a stroke, I mean, even if you did that on one patient, you've done your job. And we've done that on a number of patients. So that was one. We've helped a suicidal patient. We helped a patient a few weeks ago that, is dealing with cancer and a number of other things, and then come to find out she's got a bipolar adult son living in her home that's, physically, concerning to her, and she's living locked in her bedroom. And so how do you just expect someone to, be able to take care of their health on a day-to-day basis when they're dealing with all these other situations going on at home? So for me, this is really how we're going to move into the future of having these small micro interactions with our patients and our consumers on a regular basis. And the minute that need comes up, our team is able to intervene and address and put them into the right site, right place, right care, right time, all those things that we talk about in the value chain. How do we actually do it? We need technology. We can't do it alone. And I think all of us that are on the line here know what happened to resources in the healthcare system post-pandemic era. I mean, people have left healthcare. And so I think as leaders, it's really important for us to look at the technology is not the answer. And I want to speak to the design piece that Nabil and his team spent so much time with me. The design is just as important as the technology of how this program is actually built. So.
Yeah, you hit on a number of key topics and points there, but the concept of business model really ties into it's keeping your core. I love hearing about how you keep your core mission about serving patients, helping them wherever they need support, thinking about prevention as opposed to management after the fact, but then tying it back into a business model that's sustainable and works for the organization and for the providers who are at the heart of it all. Love hearing that and totally see it. Along those lines, obviously you decided to make this decision to invest in the chronic care management program. And, with that, obviously we're grateful to have had the opportunity to partner with you and your team. But after you made that decision, why didn't you decide to just do it on your own?
We actually already did. CCM is not, a new concept. I think using the technology and the design of the program, that's sort of the new concept here. So, the other thing too is I want to give a nod. I don't know anybody at CMS really, but give a nod to CMS and CMMI, because this year in 2020, CMS made an extremely bold statement. There's a number of things that they did with the code that we bill for chronic care management, but they also increased the reimbursement to improve adoption of these types of programs. And so, I think that's really critical for us in our success. Is we tried to do this before with a standalone EMR, and the number of activities that a care manager might do throughout a day, returning a phone call, doing a refill, scheduling an appointment, how do you quantify that? And I think that's really where Family comes in and solves that problem for us. Everything is really captured in the day-to-day activity with the patients via the texting platform. So that allows us to record the time that we spend with patients very easily. And then it doesn't become an additional administrative burden on our team to sort of record that time. And I think you guys have put a lot of focus on how that works for the end user, and even just continuing to improve that over time is really exciting.
And Lisa, remind me, you're a Cerner client, right?
Yeah, we're a Cerner shop. Yeah.
Okay. So despite that fact, you still just couldn't get CCM done with Cerner alone.
Yep, exactly. Okay. I don't know that I've seen some other clients try it with, or some other providers try it with other EMRs, but I was actually just in a physician practice last week, and they were telling me they sort of hit that 500 threshold, and they have 2 staff members, and they just feel like they can't do any more. And so when you think about, most physicians today have active panels of at least 2,500 to 3,000 patients. How do you deliver personalized care to 3,000 people every day, all the time, on an ongoing basis? It's really impossible. And with the shortage of primary care physicians, you've got all these different models out there, and they all do great things. Direct primary care and, fully capitated models like ChenMed and Iora, and those are all great and they serve a purpose. Where we're at in our space is we need to build a program that can live within the fee-for-service environment, because that's where we are at our point in our journey. And I don't want that to be a barrier for not doing something.
Internally, what were some of the concerns that the leadership team and some of your providers had about working with the Family team? How did you end up describing or just demonstrating ROI to sort of satisfy their questions, and how did you really overcome those concerns?
Yeah, I think that was you and I in the lab for many hours, right? On the line, and I'll give you all the credit in the world. Nabil is a financial genius, so thank you for all of your help there. And I'm not a spreadsheeter, so thank you so much for helping me with that. It was really, we had to take the numbers and tell a story, right? So, again, back to advancing the health of communities we serve. Yes, we need to make money in order to keep the staff and really invest in the infrastructure of this program, but that's not the end game. The end game is Are we driving that outcome? And so what I did is, we have a Medicare shared savings program with 11,000 Medicare beneficiaries across 100 and some odd primary care physicians in our community, where the majority of our physicians are independent, aligned physicians. So right now, this program is housed in our employed physician group, where we're, sort of testing those things out with the intent that this would be available to independent physicians in the future. But, we had to we're managing $120 million of spending on 11,000 patients. And so if I'm responsible and our providers are responsible for achieving an outcome and lowering the cost of care, and I've got, all these different variables going on, different EMRs, patients spread across multiple primary care physicians, you've got, even within primary care, you've got segments of populations, right? You've got your high risk, you've got your medium risk, you've got your low risk. All those patients need different things at different times. And there's no way that we could physically handle or manage customizing treatment plans for that number of patients. So that was really how we told the story, was looking at the big picture of the total spend, how many patients are even within our own employed practice, and what could we take as far as the industry has put out on the ROI for chronic care management, apply that to our own spending and see what comes out at the end of the day. And really, that's the goal that we're chasing, right? Is how do we lower the cost? And I think as a value-based care leader, it's exceptionally difficult to prove a negative. How do I prove that I prevented someone from having a stroke? I mean, I really can't. But at the end of the day, utilization that's aligned with primary care physicians is always, that's where it should start. That primary care physician should have the say in when do you go to the specialist. With Medicare, the way the plan is designed, beneficiaries can go into any physician without referrals or without direction. And you find that often, like their sister or their neighbor refers them to the podiatrist at Rush. And nothing against these big academic centers, but really where we can effectuate change in our patients is within our own community. So keeping these patients tightly aligned with us is really, really the end game there.
Makes total sense. So you've talked about, you struggled to do it on your own. You found a new vendor to do this. You got it through approval. Now, kind of the last step was this decision to really make CCM into a service line. So how did you really kind of approach this concept and really make CCM as its own independent service line? And what were some of your goals and the key challenges you faced in doing that?
Yeah, so I think, you don't know what you don't know, right? I didn't know how quickly patients were going to adopt and sign up. And I know that you all came to the table and said people are going to convert and sign up. But because of the influence of the pandemic, the traditional model of like enrolling a patient in CCM, where they would come and see their provider and the provider builds a G code and has a conversation, I knew there was absolutely no way that that was happening in the current state with the pandemic. So we forwent the G code and went straight to enrollment and started to get people signed up. And I happened to be on vacation the week that we launched, and clearly very connected to what was going on. But people were signing up in the hundreds and then the thousands, and all of a sudden we had so many patients and one person. And we had to stop and we had to get our arms around everything that was going on and start adding staff. And when that happened, it was like, now we have a team. Now I need to, create relationships. Our team works fully remote. So, the really exciting thing about how we set this program up is there's no capital investment. We started this program hiring staff. We set them up to work from home. And then there was, just amazing alignment with the operations leadership from the medical group. They were so hungry to do something better for their patients that, I just had people coming out of the woodwork to help me make this happen. And I really just, that's what drove the success of this program. As far as it being a service line, I think, you just didn't, like I said, I didn't know what I didn't know because I didn't know how quickly patients were going to adopt this. What I've been able to do over the course of a year is arm the team with community resources. And we are now delivering food bank benefits to our screened patients that have identified food insecurity issues. We're about to support patients with a community benefit that have difficulty paying their utility bills. So when you take a step back and you start to look at it, there's a number of patients, and you guys can see on the screen, that have signed up for this program. Their patients are fully aware we're billing Medicare. You know, they see their EOBs. They're finding so much value in this program that we've been able to continue to grow over the course of the last 12 months. Just really has been wonderful to see.
Yeah, I can personally attest the results that your team has achieved are nothing less than stupendous. And you know, when you think about what this has meant for patients and the quality of care, obviously it's huge. Do you mind sharing some stories that really come to mind about how this has really impacted your community, as well as kind of how the program has impacted the doctors and the providers at Silver Cross?
Yeah, so I'll tackle the community first. You know, again, just a number of stories. I actually got an email this morning on the way in. A patient reported to her care manager that because of this program, she's now able to prioritize her health and that she has support in doing so. And that really is what we're here for, is how do we connect with our patients and our consumers and meet them where they are? You know, I may have a diabetic patient that wants nothing to do with the diet and is going to just be on insulin and be okay with that. And we need to be okay with that. And we need to be there for that patient in the way that they want us to be there for them. It's not for me to say like everybody should go on a diet and, you know, change their lifestyle. But we ultimately know that those are the things that need to happen to improve outcomes. We know that lifestyle is directly related to chronic conditions and how pervasive they are in someone's life. Now, how they end up there is, again, back to the social determinants. So some of the other examples that, you know, have come to me over the course of the last year, being able to assist a patient out of her home who is being physically abused by her own family. Stories like that just really, if you go home at the end of the day and you're just extremely grateful for what you do have and realize that people are living during, you know, very difficult times. And the fact that we can provide both that social and emotional support in addition to medical advice, I think is just really critical. The providers were a little bit of a hurdle in the beginning, and it's really on me because I wasn't quite sure how to articulate exactly what we were doing, and the physicians would come to me and say, well, what are you talking to them about, and when am I going to know about blood pressures, and different questions like that. And it just really kind of led me to kind of help the physicians understand that the medical model versus the chronic care model, and we need a partnership, right? So I'm surrounding the patient, I'm surrounding the provider with additional resources, and our team is getting reimbursed by Medicare to spend 20 minutes with that patient, whether that's connecting them to, you know, addiction specialists, connecting them to community services. We had a patient that's so arthritic, and we had a huge snowstorm in February, and she couldn't shovel her driveway to get out to the grocery store. So we were able to tap into a community resource that came over and shoveled her sidewalk. I mean, these are the small things. If that patient can't get out of her home and get to her doctor's appointments or get to the grocery store, I mean, that really starts to affect their outcomes in other ways. And so, you know, I would say those are probably a couple of the stories that have really, you know, sort of hit home for me, plus the one we shared earlier about the patient that was, you know, having the chest pain and shortness of breath. So.
No, those are fascinating. You really are actually hitting on, you know, what I oftentimes think of as true outcomes, right? It's not just the outcome 12 months from now, but it's the outcome of, can I get my medication? Can I go see the doctor, et cetera?
Yeah. I mean, that's even a great point, Nabil. We had a patient that, you know, seemingly was doing fine. We did a check-in around medication adherence, and he was able to disclose to the care manager that he was prescribed a medication that he really can't afford. And he was too embarrassed to say anything to his physician. So I think that's another critical thing for people on the line to understand is I was completely shocked at what people were willing to disclose over a text message. And I think maybe that little bit of anonymity, that it is a text message. You do have a relationship with this person though, that they're sharing, that there's really struggles going on in their lives, and how can we step in and help intervene. That was a quick message sent to the provider through the EMR. The medication was changed, the new med was sent over, the patient's still adherent. So I think those are the kinds of things that I want people to hear, that you just don't really know what's going to pop up. Today they can afford the medication, tomorrow they can't. And because we do these micro check-ins with our patients on a weekly basis, we're finding out when those events are affecting their lives, and then we're able to intervene in those quickly.
Love that. Love hearing about that. That's fantastic. Let's shift it slightly here. And we've talked a lot about obviously sort of internal questions, operational concerns, and sort of the challenges that you overcame to set up the program to build it into an independent service line. Let's talk about, I think kind of the bane of the existence of arguably every pop health department and team around the country, which is everyone wants to do pop health. Not everyone has the budget, or you have a limited budget to do it because we don't have an infinite amount of resources and money to spend on the things that we know are good and kind of the core mission of healthcare. So how's this program really worked out for Silver Cross financially?
I think, we're now seeing operating margins over 30%. That's been a struggle initially, but again, highlighting the partnership between us and family. The way that I structure this team is they're not medical assistants in a clinic doing this part-time. We hired a team of people that have, and these MAs and nurses have well over 10 years experience doing preventative and population health type of work. And so I really wanted to make sure that we had a team that could pick the ball up. They know what they need to be doing. And, this is where enabling great clinical people to do their job, you're going to get the end results that you want. And I think that's really been a huge success for us financially, is being able to see the return, the recoupment of the reimbursement from Medicare. And we work with our patients. We know the ones that are financially challenged, and we have legal ways that we can go about helping support them in the event that their supplement doesn't pick up the remainders and things like that. And so it's, again, been a partnership between us, family, our billing company, and our ops team and our providers, making sure that patients that really need this program are getting access to it.
Lisa, if I could just pull in one thread there, one of the things I often hear from clients, from prospects, and just sort of generally within the healthcare community at large is the reality is in the current era of, arguably we're going through inflation, especially at the wage level. People tell me it's really hard to find resources, or it's really expensive. How have you been able to, still run this program successfully in spite of all that, and as a small independent hospital in Chicago?
Yeah. I'm really proud, honestly, that we have a vehicle for clinical professionals to work from home. And I would say there's not a whole lot of organizations other than like insurance companies out there that have quite figured this out. And, that's been a challenge in and of itself. You've got all the PHI and different things like that you have to be concerned with. But because of the pandemic, it just literally accelerated our ability to put care teams at home and connect them all virtually. And it's been wildly successful. So number one, I don't need any physical space for these people to reside in. And that's a huge cost savings. I'm able to pay at the top of the pay scale for people like this because I don't, again, have some of these other overhead costs that are happening. To be frank, I think people are looking for something different. And I had zero issues hiring for these positions. I had multiple applicants every time I posted a position, and I probably have 10 or 15 more for the next time we're ready to grow again. I really, and the clinical folks love this. I mean, a lot of people in healthcare are women, and we have families, and we want to do everything. We want to do both. We want to be a mom and take care of our aging parents and be there for our kids and also have a career. And I just really hope that my team knows that there was a lot of thought put into that from my standpoint about creating an environment for them to be successful, to be happy, and to really feel like they're making an influence on people's lives. but also to really have job satisfaction as well.
Lisa, thanks for sharing some of those details on story and kind of how you've used CCM as kind of a successful bridge towards better value-based care. Wanted to take some time, though. Obviously, we've got quite a few people on the webinar here today, and wanted to open up the discussion a little bit to some Q&A from the audience. I think we're already getting some questions that are coming in. Why don't I go ahead and start with the first question? Although, Ben, do you want me to run a poll first?
No, go ahead. Just let's do the questions that people asked while we were.
Perfect. And I'll remind everybody. Feel free to ask and put in additional questions in the Q&A section on your panel here. All right. So the first question is. How do you know, Lisa, that outcomes are improving as a result of this program? And have you seen clinical improvements at scale?
Yeah, great question. I think today it's mostly anecdotal. We actually have our team set up. We're a high reliability organization. And for those that don't know what that is, I mean, we're really just obsessed with safety and obsessed with looking at when failures happen and how can we fix those. And one of the common threads around our entire organization is that every department, including our house, the main hospital, has a daily safety huddle. And so we are able to, escalate patients where we're highly concerned about maybe something that's going on with them. So we're able to directly influence that outcome in the moment. I think in the long term, what's really exciting is because I'm so directly connected to our ACO essential health partners, we've executed contracts between both family and essential health partners that we can, with the blessing of Medicare, share our claims data with the data scientist at family. And we're just in the very beginning process of starting an outcomes analysis. And things that I think I would be looking for, because I know I'm getting graded for these things in my value contracts, is my population in the hospital less frequently? Are they less frequently using the ER? Has my total cost of that member reduced over the course of time? Are the care gaps closed? Does that patient have an AWV? Those are the things that I'm going to be looking for that directly translate to success in those value-based contracts. And then on the flip side, we're tracking the consumer engagement, right? Because if the patients are not engaged with us, I mean, we have 86% of our patients that are enrolled touch a care manager every single month. I mean, that's huge, that we really have that relationship with these patients where they may not need us every day, but they are reaching out to us on a monthly basis to follow up. So that's how we're going to address the outcomes. And again, that's going to be a learning experience because I don't think anyone has that figured out. And even if you go search ROI for outcomes analysis on CCM, you're not going to find very much. There was a paper written by, was it Mathematica, published it in 2015 or 2017, somewhere in there. It was extremely small cohorts of patients, but you can see clearly the reduction in cost and the improvement in outcomes at the 12-month mark and the 18-month mark. So I think we're really in that sweet spot to start looking at that now.
Absolutely. And we're looking forward to helping show and quantify what you're seeing anecdotally and, in both individual and collective cases kind of around your practice or around your group. Let's go to a question from Brendan here, who asks, were there any challenges you encountered in enrolling patients on CCM? How many patients do you now have enrolled in the program?
Yeah, so challenges, yes. Today we're sitting at about 3,300 patients. Some of the challenges were, I spoke earlier about foregoing the visit-based enrollment, and I think that was really coaching from family and laying that out for us so we could actually see what that would look like. So developing workflows ahead of time, which again, you guys are really experts at. We had everything packaged and ready to go when we started pushing send. Initially, patients thought things were scams. So I think it's really important that you construct the messaging very well with your partner from family so that patients realize this is their provider actually reaching out to them. That's how far behind we are in healthcare, that patients thought we were scamming them by texting. I think other people just generally had a sense that Medicare patients would be adverse to technology. And I thought the complete opposite. I have a Medicare aged parents and they text. They have no difficulty with that whatsoever. Introduce a portal, introduce an app, I think you have a different story. But that's the beauty of working with family, is because the text messaging is so easy for them to use, that we didn't really find any barriers there. And then once the enrollment happened, when the first round of EOB started coming out, I think patients had a lot of questions, but we were prepared for those. And we had a process in place about anybody that wanted to remove themselves from the program, no problem. That we don't want to become a barrier, but we also wanted to make sure that patients that, maybe had a financial issue weren't being left out due to that reason. So there were a number of things that we came up against, but in partnership with you all, tackled those, developed workflows, and quickly pivoted and moved past.
Thank you. I think that that should hopefully cover that. Let's move on to a question from Joshua. And Joshua asks, what was your strategy to get 80+% buy-in from patients? How did you prevent patients from dropping out of the program?
Great question. The buy-in, I think, is really the partnership between the two organizations, right? Because the way, families sort of approach this was, we're here to help you scale the care that you already deliver. And so I think you have to come back and look at your own organization and say, what is it that's special about us that our patients want to hear more of? And I wanted my team, this team, to feel and present themselves as like a concierge to that patient. I want you to usher that patient through every step of what they have going on. Do they need to get to the pulmonologist? Get on the phone and help them make the appointment. Three-way call it, get it done. Assist them in tackling everything that they need to do to prevent these adverse outcomes. Check in on their medications, do those types of things. So I would say those, definitely were things that came up in that area.
Before I get to the next question, why don't I take a quick, let's do a little bit of quick audience participation here. And Ben, why don't we pull up one of our first poll questions around and asking what's most important for achieving value-based care outcomes. And, if I can ask you, Lisa, just sort of a follow-up to that, what misperceptions do you think are out there about how to scale value-based care programs?
Patient adoption, the providers, maybe, the finance guys, you gotta have that buttoned up. Those are some of the bigger hurdles, and not in a negative way, just they're protecting their part of the organization. And so I really had to come with an argument and a case of why we should be doing this. And so I think those were some of my initial hurdles.
Awesome. Yeah. Sorry, I jumped the gun on launching the poll there, but I have a few different options here for what people think are the biggest obstacles or challenges for scaling value-based care. But if you have a different answer, feel free to put it in the chat. So polls up on the screen if you want to answer with one of those, and then if you have a different idea, though, feel free to put it in the chat. We'll take a look at those.
Perfect. And while folks are, responding to the poll question or adding in a different perspective in the chat, let's take a question from Samuel, who asks, do you see more value in using licensed providers, RNs, et cetera, versus non-licensed, such as MAs, in CCM case management?
We actually intentionally designed our program to be nurse-led with medical assistance underneath for that very reason. I think there's very specific things that RNs should be doing. There are very specific things that medical assistants can be doing. It's our job as leadership to identify what those activities are and then help our clinicians work at the top of their license. And I know we say that in healthcare, but that's really what makes people happy, is being able to put their full heart and soul into their job and operate at the top of their license for what they've been educated for, and then hand that off to providers where it's appropriate. So I think those were, I really strongly felt, and I think the general feeling around our physician community and our medical group leadership was that we wanted a nurse at the helm, and I think she's on the line. So I don't know, Ben, if you can find Erica Hernandez. I think she might have come in today. But, you know, she took a leap of faith with me because she was the first one to come here. And I had the story all put together, and she believed in me and believed in us. And I'm really just so grateful that she's here. She is in charge of the medical assistants and their day-to-day work, their productivity, and the activities that we reach out to patients for. That really rolls into her. And we partner with the RN leadership within the medical group. And so I think we've done an exceptional job of figuring out, what does the MA do, what does the nurse do, and then where do we go to the provider from there.
You know, let's shift gears slightly to another poll question, I think, for you and for the audience. And you know, we're obviously trying to talk about value-based care and what are kind of the bridges towards moving to a value-based care system. And you know, I think one of the themes that oftentimes comes up is this concept of proactive care management. And so, you know, we're going to ask a poll question for the audience about what percentage of their patient population is receiving proactive care management. But, you know, for you, Lisa, in particular, you know, why do you think it's important that, you know, about a third of your eligible population is getting proactive care management?
Well, there's a variety. I mean, even somebody like my example with the person that had the bipolar child, you know, on paper, they didn't look like too high of a risk. Yes, the person's dealing with a cancer, and that's definitely something that's high risk. But they didn't have, you know, end-stage renal disease. They didn't have, you know, CHF or COPD, and the things that us value folks are like, these are your high-risk patients, and you got to focus on them. Anyone at any time could become a catastrophic situation, a car accident, a heart attack, a stroke. I mean, being able to work with patients on daily lifestyle activities, even simply taking your medications as prescribed, positively influences that. And so I think proactive care is all diet, you know, nutrition, sleep, all of that, you know, family connectedness. And we're able to do all of those things with having access to family. It makes it easy for our care managers to really touch on all of those topics. We had a patient share with us that has really been struggling with GERD, and her provider and the care manager nurse have her on a mostly plant-based diet, and she's reporting like little to no symptoms from GERD by, you know, sticking to these dietary recommendations on a regular basis. And we help her with recipes, and we encourage her and things like that. And so I feel like, you know, you have to think about what your patient is dealing with, and then how do you look at prevention for that patient? Because if you have one of those, what we call seriously ill patients, that's that top 5%, they need a whole different set of resources, palliative care, home health. I mean, you've got to get an army around those patients to prevent those readmissions and those hospitalizations. So it really depends on where that patient is in the journey of their health, and then how can we assign the resources to them appropriately.
Lisa, that's a perfect segue to one of the questions that I see on the screen here. This one's from Misty. As a part of moving to value-based care, are you seeing providers utilize more home health and hospice? Both services result in cost savings and improving quality and outcomes.
Yep, definitely home health. And then we're really heavily focusing on palliative care in our organization as well. And I think if you go out there, like less than 10% of ACOs have a palliative care strategy, and shame on us. Palliative care has been an enormous, both one outcome improver and cost savings for us as well. And the beauty of the CCM team is they're helping me identify the patients that are falling in the cracks. And then we're able to then task the provider, hey, I think Bob would really benefit from a palliative care consultation. If you approve, then I will go ahead, you know, generate the order. Then the CCM team picks it up and contacts the palliative care company and gets them dispatched to the patient's home. So the answer to that is yes, yes, and yes. And also within the Medicare shared savings contract, more on the hospice line, the agreement that we have with CMS, if our patients make it to hospice, the cost associated with their care for the 6 months prior to their death is actually removed. And we know that's really when a lot of activity and family involvement, you have certain people that want them in the hospital. We're just really not equipped to care for people at home. And that's my focus, is how do we get more care in the home?
Thank you. I see a great question from Jean, and I actually want to tie that into a poll question for the audience as well. So let me start with Jean's question, and then Ben, you can pull up the poll after this. Jean asks, or Jean writes, great job. I'm missing how those resources can be applied at scale when we approach 75 to 80 million Medicare beneficiaries. Your thoughts? And Ben, if you don't mind, pull up the poll question for, at your hospital or practice, how many patients can one FTE provider manage? So, taking Jean's question, Lisa, about how do we approach and how do we use our existing resources at scale? What's been the impact at Silver's Cross of giving your providers tools like Family to manage care for so many patients? If you could maybe combine those two together.
So I'll start with saying that we all have to contribute where we are locally. I think no one person, no one entity is going to drink the entire ocean. But if you look or read anything coming out of CMMI, the Center for Medicare and Medicaid Innovation, they have just released this year, I think it was September of last year, a very bold statement that all Medicare beneficiaries will be in some type of value-based arrangement by 2030. So if you are not thinking about how you're going to do this type of work in the future, it is going to be extremely difficult to really deliver care. We have to get away from the thinking that everything has to be done at the hospital. And even our leadership here has invested so much in developing our ambulatory strategy that this really fits right into that. We know that the hospital needs to be reserved for the sickest of the sick, and patients coming in for surgeries and things like that. And so my comment is, start to dig away at the work, because it's endless. And to answer on the number of patients, the way that Family presented, and we actually are seeing it in real time now, one medical assistant can handle a panel of 500 patients. And so what we've done is we've dedicated one care manager to each physician practice that has a panel of 500 patients. That's their responsibility. Learn your provider's protocols, get very familiar with your patients, help your physicians out with all of those sort of tasks on management of that chronic care patient, and be a resource for that provider. I actually have physicians telling me now that they recognize that they're getting an extra medical assistant for every 500 patients that they have enrolled in this program, and they want to put their entire panel in this program. And so I think those are the things that we have to highlight to the physicians. And the other thing that I think has been huge is storytelling, the oldest form of communication. So what we're doing today, save these stories, tell them to your physicians, then they will start to understand how these programs are helping both their patients and them succeed. Our nurse manager is saved for the higher risk of our total enrolled population. So she has, give or take, 150 to 200 of the sickest patients. However, when one of our patients being managed by a medical assistant expresses a clinical concern above their ability, above their licensure, it's turfed up to the nurse for management, and then into the provider where necessary.
So Lisa, I know we are coming to the top of the hour, and if we've got time, maybe we can do one more quick question here. This one's coming from Vern, who asks, do you focus primarily on those patients who are in the top 5% of cost? How are they identified to you?
Yeah, absolutely not. We actually are able to address all of our patients. The cool thing about me being involved in this type of program, and also in the value-based side, I look at patients' claims data all day long. And so I look at high-risk patients, and I'm able to then crosswalk the analytics data that I have on our patient populations that are part of our value-based contracts, and help the care manager. The care manager is doing the day-to-day talking. I'm coming in with, hey, this person's got all of these, sort of high impact conditions. They're on 22 different kinds of medications. Do we have all that stuff in their chart? Making sure that we really have that 360-degree view of the patient. You know, we have ADT alerts coming to our teams on who's getting discharged from the hospital. So we know that we can pick that patient up immediately. You know, 72% of our readmissions across the country come from medication reconciliation issues and medication errors. So knowing what's going on, you know, academically in value-based care, and then to actually be able to put it into action is just been the coolest thing ever. So I'll just say that.
Well, Lisa, I know we're now at 1 o'clock, or sorry, 2 o'clock Eastern, I guess 1 o'clock Central. And just want to thank you so much for your time, all the questions that you were able to answer. And I apologize to everyone who's still on the line. I know there's still a couple questions that we didn't get a chance to get to. But if you have any follow-up or anything else that you'd like to learn and understand, we can continue the conversation on a one-on-one basis. If you message Ben at jaanhealth.com, so it's JAANHEALTH.com, and we can set up some discovery calls and share some more details around how our team was able to work with Lisa and her team at Silvercross, as well as many of our other clients around the country. But Lisa, really, again, thank you very much. This was an incredible conversation. Hopefully it was productive and helpful for everyone on the line.
Thank you so much for your time, everybody.
Thank you.
Thanks so much. And I'll be sending a follow-up email to folks here with if you just and you can reply to that if you'd like to continue the conversation. Thanks, everyone.
Have a great day.
All right. Take care.